everyone, and welcome again to another RBMO interview. This time joining us is a Barcelona embryologist, Iris Martinez. And Iris is the first author of a recently published study in RBMO on blastocyst collapse and re-expansion after for vitrification. Now, the study specifically tested two methods of induced collapse, by laser, by pipette. But before we consider the study specifically, I want to ask Iris more about the concept of artificial collapse before freezing. And Iris, if we can start, it is a hot topic, I think. But first of all, let's get back to basic embryology. And what is the rationale behind induced artificial collapse of blastocysts before vitrification? I mean, why not leave them intact to go their own way?
Thank you. Well, the rationale behind collapsing the blastocyst is, first of all, considering that this technique is worked in expanded blastocyst. We only consider it when we talked about an expanded or fully expanded or further stages like hatching or hatchet. The idea is that when the blastocysts are so expanded, they are full of blastocytic fluid.
Yeah.
And if we think in the basics of vitrification, all protocols around the world are based on two steps. The first is a pre-equilibration step, where we place the embryo and wait that the water content is substituted by cryoprotectants that first avoid the presence of water, because this presence of water in further steps could lead to the formation of ice. So in this pre-equilibration step, we remain mostly from 3 minimum to 12 minutes. And in this process is where the change is done. The rationale behind collapse is very understandable. It is that we help the embryo to do this osmotic interchange of water and cryoprotectants by removing a considerable part of his water content that is in form of the blastocytic fluid. So it's like that we help to the embryo to do this osmotic interchange that may induce in him an osmotic also effort or osmotic shock. And two, we ensure or try to ensure that all the water content is removed. So we make easier that all the cryoprotectants enter into the cell and no water is remain.
Yes.
At the moment that we plunge the embryo into the nitrogen, and we avoid the ice crystals formation.
Okay, I understand that. But is it fair to say that a lot of groups don't use this artificial technique, that they simply leave their blastocysts intact before freezing? That's
what happens with artificial collapse. As many other ads-on, they make sense, but then they make sense theoretically, but when we go to the practice, they need to demonstrate that they add a real value. That for us in the clinic, of course, is not theoretical things. It is clinical pregnancy live birth rate. And with these techniques that are add-ons need to demonstrate much more than the basic techniques, because they add an effort for the lab, because we should add a previous step to the vitrification.
Yeah.
And also we are adding a manipulation to the embryo. So
and it is an invasive technique, isn't it?
Is it? So we have to be very sure that the ratio cost benefit is high. And
Absolutely.
that's what happens with this technique, that we are researching it or trying it a lot of years ago. But still, you see that there are a lot of laboratories that use it because they are convinced, or at least in their data set, their own conditions, they see a real improvement. But then
well, can I interrupt there? I mean, where is the improvement? Is it simply survival after vitrification, or are you looking further towards birth rates, for example, or clinical pregnancy?
The labs who use it, they rely on not only the survival, because also with vitrification, we are in a very gold standard procedure. The practice around the world is very good. We have achieved a good, very good survival rate. So it is very difficult to improve a 98% survival rate.
Okay.
Probably is not significant at all, like to increase that 2%. But the important is and what laboratories study when they assess if they introduce this technique or not is the clinical pregnancy rate, the live birth rate, or even the miscarriage rate, because it's also what I tell sometimes to our patients. When we assess the survival of an embryo, nowadays, unfortunately, we still only have morphologic or morphokinetic criteria. We don't see if there is another inner or something that we don't see affecting the embryo that could be produced by the vitrification, but we don't see it in a morphological level, and probably with the collapse and the rationale behind it, that is making the embryo suffer less during vitrification, could induce an improvement.
Yeah, and what about the re-expansion time? I understand that will artificial collapse sort of improve the re-expansion time, and that I think has got some bearing on the outcome.
Yes, that's what at least we have observed in our own data set. That is not very large. It is enough, but not very large. It is 2,050 embryos. 250.
Yeah, that's true. Yeah. And it was all retrospective, wasn't it?
Yes, but even in a very small, in this small size, we see a very significant differences between the collapsed and non-collapsed blastocyst in the re-expansion rate.
Yeah.
And there's evidence, and it started in 2018 when the groups that are classically working with the morphokinetics, as in Valencia, for example, Marcos Meseguer and these people, they started to study everything that can be studied with time-lapse. And one of the things, of course, is the behavior of the embryo after warming. And since the beginning, it has been very clear that the quicker the re-expansion, the better the clinical outcomes. And it is also has been demonstrated not in probably with the time-lapse tool, because not everyone have it, but there's also abstracts in congresses or very more simple papers that say, when we transfer an embryo, and in the moment before transfer we see it is full expanded, we have higher pregnancy rates than if we observe that the embryo is still collapsed at the moment of transfer. And even talking with colleagues about this paper, I had one of them that told me that in his lab, they discarded those embryos that didn't re-expanded in 2 hours. That probably would be very surprising. For me, it was surprising, and I was like, but it did the embryo show any morphological or low like death, lossy or sonar?
Exactly, I can hardly believe that.
And he was like, no, but we internally knew that those blastocysts that didn't re-expanded in this given time,
they won't form a pregnancy.
they will form it in a very small percentage, and we preferred to.
Well, I'm surprised at that, I must say. But let's just get that clear. There is an association then between the re-expansion time and the clinical outcome of the transfer. That's in terms of pregnancy or birth rate.
That's what it is in the literature. That is.
Yeah, yeah. And what you're saying is that you believe that an artificially collapsed blastocyst before vitrification will have a better re-expansion time after warming.
Yes, that's something that we have seen very clear in our data set, that both laser-assisted and ICSI pipette-assisted collapse reduced shorter expansion rates. We have in the control group, I think we had 1 hour of period of since the point of expansion. Since the initial point to the final point of expansion. And in the case of collapsed blastocyst was 0.6 and 0.5. So it was much shorter. And we observed also that in those embryos that gave a pregnancy, we had also a significantly statistically significant shorter expansion times compared to those blastocysts that didn't produce a pregnancy. Although this data was mixed, a bit mixed between the controlled and the artificially collapsed blastocyst. And that's why we didn't see a statistically significant difference between a clinical pregnancy rate in the collapsed compared with the control groups.
Okay. And let's say a quick word about the study, because what you were doing in the study in RBM Online was comparing the two methods, one with shrinkage via the pipette, via the ICSI, and the other with a laser-induced collapse. I mean, what were your findings there with that small study?
Our findings in this sense that are also interesting because we see a difference between the laser and the ICSI pipette, because we see that the laser-induced blastocyst re-expanded even faster than the ones collapsed with the ICSI pipette. And our hypothesis was that in the case of the ICSI-assisted pipette, ICSI pipette-assisted collapsed, we let's say it artificially remove the blastocellic fluid until both the one point of the embryo on the other side get attached. So there is no liquid inside. There is no intracellular content inside. While in the case of laser-assisted collapsed, we only did laser pulse on the membrane. So we broke this tension that the embryo has when it is expanding. And we left the embryo maximum 5 minutes to lose the water. And although it lost probably the 30 or 40% of his blastocellic fluid, in any time we saw that one side of the embryo and the other are closed together. So our hypothesis is that probably then for the collapsed blastocyst was easier to re-expand than in the case of ICSI pipette, that probably they are much closer, too much closer, and this union between cells could make the re-expansion a little bit slower, because having in mind that this lower expansion of the ICSI pipette blastocyst was even faster than the control ones.
Sure, but nevertheless, what you found was that the shrinkage via the laser was associated with a shorter re-expansion time, and that's presumably what you would recommend from this study.
Exactly. One of our clearest readings of our paper, or one of the clearest ideas that we wanted to stress, because it's one of the most interesting is if you believe in collapse or you no, it's not that you believe, because science doesn't work like this. But if you want to try a collapse and you want to try to in your lab, we recommend laser before.
Yeah.
More
And
than
what about the bigger question then? We'll stop now, Iris. But the bigger question, I mean, can we say fairly that you do believe in artificially collapsed blastocysts before vitrification? I mean, it is controversial, but I'm assuming that you're on the side of
yes.
action rather than leaving it.
Yes, I am a believer in this sense, but also because in my experience, in the lab that I'm working now, we see daily that the huge blastocysts that were hatching in the moment of vitrification, they are AA grade hatching. They are like very nice blastocysts that we think in a fresh transfer will attach perfectly to the or at least to our hypothesis, of course. But they are at that night that you imagine them. But we work in our case in a freeze-all strategy, so we don't do any fresh transfer, and we have to vitrify it. And we think like, oh my God, I have to be very sure that I'm dehydrating well this embryo in the first step of the vitrification, and also in the second step, that is with much more cryoprotectants. The problem is that in the second step, you can't be for more than 1 minute, because it is a toxic media, because it contains too much permeable cryoprotectant. So we, before vitrifying a big embryo, we also do the effort of, okay, let's do it with a lot of care, because we see that when we are warming this kind of big embryos, that they were very nice, we sometimes see that they are not surviving well. And when we see that, it's like, oh, probably ice crystal, because you see it in the...
Yes.
So our hypothesis is that probably the person that vitrified this embryo didn't make very conscious this step, and left a little bit of blastocytic fluid. And you can be in your own lab relying on the very effort of the people. We need like constant results.
And yes, set protocols and proper systems. It's a very important point that you're making, because I guess as the years go on now, that the majority of blastocysts that get transferred have actually been vitrified. So it's not as if, I guess there are obviously still fresh transfers, but they're getting fewer and fewer as time goes on. So there have to be, I think, these quite strict protocols about vitrification. And of course, we haven't yet got that, have we? There's a huge amount of variety in how it's done and what the approaches are.
Yes. Then I talk with other colleagues that probably have other vitrification media, and they tell me, okay, so I don't have this problem, or at least, or probably their staff is very well trained in this sense, and they tell me, no, I don't have any problem with the full or hatching blastocyst. They survive very well. But then I talked with another colleague, and they told me, look, when I observed that the bigger blastocyst that I had, the worse this result was. And it is for an embryologist, it's like very frustrating, because you think, my God, this blastocyst had a very high potential of implantation, and because of the technique, probably I am reducing the possibilities. And the second thing where I think artificial collapse probably comes back to a hot topic now is, I guess that you have heard about the ultra fast or the fast vitrification protocol.
Sure, yeah. We can't get into that now, but
sure.
But I mean, in fact, the fact that you raise it, of course, it reflects the fact that there's a huge amount of variety and difference of opinion, different techniques. Now, in vitrification. And we don't have set systematic protocols yet. And, and of course, this artificial collapse is just one of these ups and downs, variations that we're finding in the vitrification protocols. We're going to have to stop there, Iris, because we've gone on a bit longer than I wanted. But it's very interesting. And of course, it is going to be a bigger and a bigger problem, really, because vitrification, especially of blastocysts, it's getting a greater and greater part of reproductive medicine. So we're going to stop there. I do just want to end by reminding people who are watching that you're based in Barcelona, but this study originates from your work in the lab of Thomas Ebner in Austria. And then it's mainly his group. But I want to thank you very much. It's very interesting. And of course, it's pointing to a much bigger question that we've got to ask about vitrification and the protocols which we're going to apply. But in the meanwhile, thanks very much and for joining us for RBM Online.
It was a pleasure. And thanks for Thomas too for all the work and the collaboration.
Good, thank you.